Hi, Dr. Rao. So you're a urologist and you see a lot of prostate cancer patients. Many of those prostate cancer patients are newly diagnosed, and I imagine a fair percentage come to you that are worthy of considering active surveillance. They perhaps a Gleason 6, maybe one or two cores, 5% or something, just sort of like a run-of-the-mill. If you harvest biopsies from everybody in America, you're going to get a large number of those guys, and it would be insane to cut them open and remove their prostate and disrupt their quality of life when there's really little to offer them in terms of longevity or, some positive health advantage. So genetic testing is what you're focused on, what we're focused on today. Why would somebody who's sort of understanding themselves as an active surveillance guy, why should he go for another saliva or blood test and find out what his, DNA is telling him?
Yeah. So, I think when it comes to genetic testing in patients who are doing active surveillance, there's a few questions to consider. First thing is there a family history of other types of cancers that could raise the red flag that you may have a genetic mutation? So some of the things to consider is there a family member who has breast cancer, pancreatic cancer, ovarian cancer, colon cancer? Some of these cancers are sort of linked to DNA mutations from which you could have prostate cancer, although maybe your sister had breast cancer, but perhaps both of you have the same DNA mutation that was passed down to you from your parents. So first question to always think about is there anybody else in my family who has cancer? And if so, that should be brought to your doctor's attention, because that is one reason to consider doing genetic testing. Secondly, on patients who are doing active surveillance, there are a few research studies that are out there that look at prostate cancer patients who have a DNA mutation. And in those patients who have BRCA mutations or a variety of other mutations, the prostate cancer is thought to be potentially more aggressive. They might have a higher chance of having more aggressive prostate cancer once the prostate is actually taken out and looked at. They also have a higher chance of having metastatic prostate cancer, and they're also at risk of having a more aggressive type of disease than you initially saw in the biopsy. As you may or may not know, roughly 25% of patients who have prostate cancer, if you take out their prostate, you might find more aggressive disease in those patients than what you saw in the biopsy. So we're always looking for clues, in my mind, to sort of find the patient who's a good candidate for active surveillance, but use more and more evidence of different sorts of data to make sure that that patient is good for active surveillance. As you alluded to in the past, some patients might get MRIs of their prostate gland looking for what some people refer to as a hot spot that might harbor a more aggressive type of cancer. Some patients might do PSA testing, and if they see an aggressive jump in that, they might do a repeat biopsy to look for cancer. Other people use things like testing of the biopsy sample itself to see if there's any clues of more aggressive cancer than what the biopsy and the PSA might have shown. So another thing to consider, as you said before, we're already talking about 2, 3, 4 types of testing. Why add another one? Well, it's because we're just learning to integrate this variable amongst others to sort of better define who's a good patient for active surveillance and who isn't. The biggest fear, I think, for most urologists is getting the treatment plan wrong. You want to see every one of your patients do great, and you want to see everybody turn out well. And although all of us know perfection is a difficult thing to obtain, especially when it comes to treating patients and taking care of cancer, it's at the end of the day, that's our goal, is to get smarter and do a better job than we did last month or yesterday or a year ago. So I think integrating genetic testing into the idea of active surveillance will eventually be determined to be useful. But at this current time, I think urologists across the country are still trying to figure that question out, and it hasn't been 100% answered as of yet.
Okay. Thanks very much. I guess active surveillance people have yet another choice on their plate and something to discuss with their urologist or even their PCP, see if they want to follow through on things that may lead to understanding other diseases for other members of their families and such.
Right.
Thanks very much.
Thank you.